Good evening, everyone. This is our keynote speech, and I've given the lucky task to introduce our keynote speaker. Which I will eventually be able to do. Professor Damon graduated from Maastricht University Medical School in 1983, and then achieved his PhD in pharmacology at the same university 4 years later. He then came to the United States for 1 year of fellowship in pathology, and then returned to Maastricht and did 5 years of residency in pathology. At Maastricht University, Dr. Damon became associate professor, quickly followed that by full professor, and very impressively became chairman of the department in 2001, where he was, for that decade, the chairman of pathology in Maastricht. More recently, he's moved on to the University of Amsterdam and is professor of pathology of atherosclerosis. He has authored more than 220 papers, peer-reviewed papers. He's on a number of boards in some societies I'm not familiar with, I must admit, but they have really lovely names like the Rembrandt Institute of Cardiovascular Science, the Dutch Heart Association, Niels Stenson Foundation. I'd like to know who Neil is. He's on the executive board of research at the Amsterdam Medical College, and is on the editorial boards of arteriosclerosis, thrombosis, vascular biology, where he's an associate editor, as well as the Journal of Pathology. I'm sure I've left most of these things out that lead him to this very impressive and exciting field that he's undertaken, which is the heart-brain connection and intracranial atherosclerosis. So without further ado, Dr. Damon, please come up and deliver your address. Thank you.
Well, thank you for inviting me to this nice society. And so I did a lot of extracranial atherosclerosis work, did a lot of coronary work on coronary atherosclerosis, a lot of carotid atherosclerosis the last 10 years or so. And a couple of years, since a couple of years, we really got interested in what's happening in intracranial vessels. So I'm just going to tell you our adventures into the brain. So these are the topics of my talk. I'm going to tell you about an approach that we set up in the Netherlands with a lot of disciplines, not only pathologists, to really connect their heart and brain function. And of course, I'm going to tell you about our work on intracranial atherosclerosis, both on the pathology of that and relate that to extracranial atherosclerosis, but also some imaging of intracranial atherosclerosis that we're working on together with the Utrecht University. So what is the evidence for that really connects the heart and brain function? Well, there is a lot of associative evidence in the literature. Already in 2007, there were several papers out that connected left ventricular ejection fraction is inversely related to the white matter hyperintensity score. You can see that on the in the figure. So the higher the ejection fraction, the lower the ejection fraction, the higher the score. And it's also known that 25% of patients with a stable congestive heart failure have cognitive impairment. It's also known, so that's another association, that that improvement of cardiac function correlates with improved cognition. And you can either improve cardiac function by cardiac transplantation, resynchronization therapy, a left ventricular assist device, or a physical activity. And there is also data from the Rotterdam study, which studies aging in elderly people, and so normal aging. And that that study, the Rotterdam study, shows that cardiovascular risk factors correlate with cognition. And they also show that arterial stiffness is associated with that same white matter lesion volume, and arterial atherosclerotic calcification correlates with cognitive function and brain volume. I'm going to show you later in the talk some of that data on atherosclerotic calcification in the Rotterdam study. So there is a lot of association evidence. There is also a recent paper in Neurology 2014 that shows that there is a significant interaction between intracranial arterial stenosis and the severity and the time of the declining in the cognition score, an MMSE score, and the daily activity score. So the higher the stenosis in the intracranial arteries, the lower both scores. So although this is all good associative evidence, there is no real causal proof for this relation. So we ask ourselves, what are the mechanisms involved? And can cognition really be improved by influencing these mechanisms? So we propose that hemodynamic changes are one of the contributing mechanisms that correlate cardiac function and cognition. So we put up the hypothesis that hemodynamic changes are an important, underestimated, reversible cause of cognitive impairment. So to test this hypothesis, we put together a really large consortium in the Netherlands, and we called that, of course, the heart-brain connection. We got a really large grant from, again, this Dutch Heart Association and other founding societies in the Netherlands. And I'm running this program together with a radiologist in Leiden, Mark van Buchem. So this study is ongoing. I'll tell you our approach. I don't have the data yet. So what we did, we formed this consortium with 6 university medical centers in the Netherlands, and the Netherlands is a small country, as you know. So these 6 university medical centers are located within a kind of a circle of 100 kilometers. They have complementary expertise in these groups, so we have several disciplines on board: neurologists, neuropsychologists, cardiology, radiology, image analysis, pathology, epidemiology, the Rotterdam study, and biostatistics. And it's really interesting that we have neurologists and cardiologists in this group, and that gives very interesting discussions between these 2 disciplines. So this is our approach. We have a clinical study, and this is the design of the clinical study. We have an epidemiological approach from using the data from the Rotterdam study, and we're doing experimental studies in mice. This is the design of the patient study. So here we study at the extreme phenotypes. So patients with heart failure, patients with small cerebral vessel disease, VCI patients, and patients mainly from Utrecht that have proven carotid occlusion. And so we are going to collect more than 200 patients per group and the control group, and we are measuring cerebral perfusion and cognitive function using the same protocol in all these patients. So patients with chronic heart failure will be tested, their cognitive function will be tested, but we're also measuring cardiac function in these patients, vascular functions of the large vessels, and we're measuring cerebral perfusion in these patients. We use a similar analysis with one MRI protocol that is running in these medical centers. We use the same cognitive assessment protocols, biomarkers. Data are stored centrally and analyzed centrally. We have a 2-year follow-up. The second approach is the epidemiological approach. That's data from the Rotterdam aging study that already includes 10,000 people. And from there we also have a cognitive status, cerebral hemodynamics, a brain MRI, cardiac function, vascular stiffness data, and biomarkers and risk factors. So that's the epidemiological approach. The third approach are the animals. And of course, in the animals, you can really test the causal relation. So also we do measure hemodynamic changes. So we're measuring cerebral perfusion, we're measuring cardiac functions. And of course, there we can study mechanisms, molecular mechanisms, and come up with candidates. These are several of the animal models that are running. We do a time course study in the transverse aortic constriction model. So you clip the aorta between the in the aortic arch. We're measuring the effects of atherosclerosis on cognitive function. We are measuring the effects of blood-brain barrier damage with PDGFB knockouts that don't have small muscle cells in their small vessels. They have a leaky blood-brain measure, and of course we can also do therapeutic interventions. So this design of this study is really involving lots of disciplines. I showed you the whole list. It's complementary and it's really translational, and it will give us strong associations in the clinical and epidemiological approach, and hopefully causality, or lack of causality, of course, which can also be the outcome in the experimental studies. And we use a standard analysis, so we can really start to compare the data from the Rotterdam study with the data from the clinical studies. The cognitive function is measured by an by a test battery that is already used in another initiative that was running for several years. That's the Dutch Parelsnoer initiative, where they did a study on dementia, and they used the same cognitive test battery, which is some 10 tests. For the biomarkers, we use, of course, systematic, so the cardiovascular risk factors and organ-specific biomarkers. And for the heart-brain axis, so the hemodynamic studies, we use a 3T MRI protocol for measuring both cardiac function, large vessel function, and cerebral perfusion. And it's really a one-stop analysis. We didn't really make it in 45 minutes. It's now 60 minutes, but it's still running. So what is this study going to bring us? Of course, we will have set up a network, and that is already running. So interdisciplinary translational VCI network. We will have a diagnostic protocol to assess hemodynamic contribution to VCI. And of course, we will show the associations of hemodynamics, of cardiac function and cerebral function and perfusion. And of course, then after all these studies, we will hopefully have defined subcategories of VCI patients that may benefit from treatment aimed at improving this hemodynamic status. And that will give us recommendations for randomized controlled trials. So where are we? We have started including patients. As of March 2015, we have included now more than 60 patients in the 4 centers that are including patients. The MRI imaging protocol is running in the 4 centers. The infrastructure to share and analyze the data is in place, so all the data are now stored in one place in Rotterdam, and they are analyzed there and in Leiden. So the infrastructure to share and analyze data is also in place, and we have started to analyze the data from the Rotterdam studies. The animal studies have started, and in fact there are really 10 new PhD students and 3 postdocs are working on the program. And of course they're all guided by by staff that was already present there. We published recently a paper on the design of this study, and the reference is down here. So hopefully in some, let's say, 4 or 5 years, I might come back and present data in a poster or another presentation and show you the data of our approach. Now some real data on intracranial atherosclerosis and the pathology of that and how it differs from extracranial atherosclerosis, and also on some imaging data of intracranial atherosclerosis and intracranial arteries. First, we we started, of course, to study the literature on intracranial atherosclerosis, and we published a review paper on that in Circulation last year. And if you really carefully study the literature on intracranial atherosclerosis, there's not that many papers published. We had to go back a long time, so we are really looking here at data from early 80s, and I'll show you the data even from the 60s. So there is not much interest in this topic. So it seems that most people think that atherosclerosis really doesn't go into the brain. It stops when the arteries go into the brain. So it's an underestimated cause of stroke and dementia. There's really limited data on phenotyping of the plaque, while there is a lot of data on phenotyping of plaques, both by pathologists but also by cardiologists and by imaging people in coronaries and in carotids. But there is almost no real work available in intracranial vessels. But of course, there's a growing interest in this area. So here are some data from a very large autopsy studies. We had to go back to the early 60s. And this is an impressive autopsy study because it included some 4,000 patients, almost 4,000 patients. And it shows you the start of the development of intracranial atherosclerosis. So it's almost not present below 30 years of age, and then it slowly starts, and then it exponentially grows up to, of course, 90 years and probably later than that. And on the right side, they compared also in a study in the 60s, 900 patients. They compared the atherosclerosis measured in the coronaries, in the carotid arteries, in the aorta, and in the cerebral arteries. And you can see there that this is intracranial atherosclerosis, and this is coronary, and this is aorta. So there's really a lack of development. So this intracranial atherosclerosis seems to develop some 20 years later than extracranial atherosclerosis. If you, as we did, we reviewed the literature. There is, of course, also correlation with risk factors on intracranial atherosclerosis. As I already said, age is one, sure, but it develops 20 years later than extracranial atherosclerosis. Gender, male are less protected than females. There's a large debate on ethnicity. Asians have more atherosclerosis than Hispanics, more than Africans, Americans, Caucasians. But if you really carefully study the literature, there's a huge effect of lifestyle. So in our opinion, lifestyle is even more important than ethnicity. Hypertension is really linked to increased intracranial atherosclerosis, diabetes and metabolic syndrome. But dyslipidemia is much less impressive than in extracranial atherosclerosis. There's a much, so it's not that much linked to intracranial atherosclerosis. This is the data from the Rotterdam study that I promised you to show. Here they looked with CT at intracranial internal carotid artery calcification, ICAC, in the Rotterdam study. Almost 2,500 individuals, 70 years of age. And at least to my surprise, so already at 70 years of age, 82% of these people have detectable calcifications in their internal carotid, intracranial internal carotid. And for pathologists, the presence of calcification is really a proof of advanced atherosclerosis. It doesn't tell you too much about the phenotype of the atherosclerotic plaque, but it's advanced atherosclerosis. It also doesn't tell you whether the vessel is stenosed or not. That's not what it shows you. But it shows you that these people, 70 years of age, 82% of those, and this is a normal aging cohort, they have atherosclerotic disease in this vessel. And in that study, it was associated with alcohol and smoking in men and with diabetes and hypertension in women. This is a study from a French group, published in Stroke in 2008, and they studied more than 300 autopsy cases. And they looked at the extent, the presence and the extent of atherosclerosis in intracranial vessels in patients with cerebrovascular disease, with proven cerebrovascular disease, symptomatic, symptomatic cerebrovascular disease. And they showed that almost 60% of these patients had atherosclerotic plaque, visible, macroscopic visible atherosclerotic plaques. And in the subgroups, of course, that had brain infarction, it was more, 62%. And this, in the subgroup that had brain infarction due to atherothrombotic disease, of course, and they saw an enormous amount of atherosclerosis, of course, 87, almost 90%, and 3/4 of them, 74%, had stenosis in their intracranial arteries. And this was, of course, much less in the patients that had a brain infarction due to cardioembolic disease, but still there, 50% of those patients also had atherosclerotic plaques in their intracranial vessels. And also, even in the group that had brain hemorrhage, 50% of those had intracranial atherosclerosis. From that same group, they also studied the extent of atherosclerosis in extracranial arteries. So in the bottom two panels, you can see the development of atherosclerosis in the common carotid artery and in the abdominal artery. And really, it's really a straight line development. So you can almost predict how much atherosclerosis you have in the common carotid and abdominal aorta if you know the age of the patient. In the basilar artery and the middle cerebral artery, it's completely different. So there is a really lack of timing, it's almost not developing here. And then between 20 and 30 years, there is exponential growth of intracranial atherosclerosis. So that the development of intra and extracranial atherosclerosis is really different in time. So it seems that intracranial vessels in the first 20, 30 years are protected from the start of developing of atherosclerosis. And then in later years, this protection is lost, and then there is an exponential growth of atherosclerosis, development of atherosclerosis in the intracranial arteries. And this is more than, this is 183 subjects. So we also started to look at intracranial atherosclerosis. This is the circle of Willis of a patient that we did an autopsy on. Here you can see the circle of Willis, and here you can see already the atherosclerotic plaques just by eyeballing. There you can see a lot of intracranial atherosclerosis. So we carefully studied the pattern of intracranial atherosclerosis, and we sampled almost the entire circle of Willis in a very systematic way. So we know exactly which vessel we sampled and which site in the vessel we sampled. I'm going to show you some data of the first of the analysis of that. We are now in more we have analyzed more than 80 circles of Willis now. I'll show you the data of 67 circles of Willis. And this is an example of such an atherosclerotic lesion. So it shows you a very large atherosclerotic lesion. Here is some lipid deposition here. And interestingly, and that's also different than in extracranial atherosclerosis, in, for instance, the carotid and in the coronary artery, we really found mainly stable atherosclerotic plaques. So no plaque rupture, no intraplaque bleeding, not much inflammation, but really stable matrix and small muscle cell rich, almost concentric lesions like this one here. So we rarely found complicated lesions, calcifications, and plaque rupture. If you really carefully look at the structure of intracranial arteries, there's also differences with intra and extracranial arteries. So this is the normal design of an artery. This is the endothelium. an internal elastic lamina, a smooth muscle cell layer, external elastic lamina, and the adventitia. And you can visualize that here. This is a lumen. Here is the internal elastic lamina. This is the media with the smooth muscle cells. There's the external elastic lamina. This is the adventitia. That's the normal design of an artery. This is how intracranial vessels look. There is much less elastin fibers in intracranial arteries. This is an example where there is significant amount of elastin fibers. There is only very small amount of elastic fibers, and here is absent elastic fibers. And if you do the quantification of that, and here are the vessels that we studied in these circle of Willis, and that and you can see that the vertebral artery and the internal carotid artery, that they have the most amount of elastin fibers. So they are really true elastic arteries, and the rest, more or less the rest, is really of a muscular phenotype. So they don't have a lot of elastin fibers in their media. Another feature of these intracranial arteries is that the lamina elastica externa, so the outer elastic lamina, is absent, is often absent. I'll show you the data here. This is an example where it's absent. So this is lumen. Here is the internal elastic lamina. You can really nicely see that. This is the media, and there should be an external elastic lamina here, but it's not present. Here you can see small pieces of it still remaining, and here you can see a very fragile but present. You can see it here. It's not as thick as here, but you can see it here. And again, here is the data on the quantification of the presence or absence of this external elastic lamina. And again, the larger vessels, the vertebral artery, that has a continuous external elastic lamina, and the smaller vessels don't have this external elastic lamina. So the structure of intracranial vessels is different than extracranial larger arteries. This figure summarizes our data. Extracranial, intracranial arteries, we think there is a morphology gradient. Coronaries, from coronaries, carotids, large arteries in the brain, intracranial arteries to small arteries. In coronaries and carotids, you have advanced atherosclerotic lesions. They have high elastin content, continuous external elastic lamina. They have calcifications, lots of vasovasorum, which we don't find a lot in intracranial arteries. They have an atherosclerotic plaque with lots of macrophages and T cells. In the intracranial vessels, they have more stable atherosclerotic lesions, so less inflammation, lower elastin content, no external elastic lamina, not a lot of calcification, almost no vasovasorum, and as I mentioned already, less inflammation. There seems also to be a barrier gradient in these between extra and intracranial. And this is what I mean with that. If you study the endothelium in these vessels, I'm going to show you some data on that later in the next few slides. There are, in the extracranial arteries, coronary carotids, there are almost no tight junctions between the endothelial cells. They have lots of vesicles and caveolae in the endothelial cells. If you study the endothelium of smaller intracranial arteries, they have more tight junctions, they have less vesicles and caveolae, and they have a specific glycocalyx. So also, it's not only the smooth muscle cells and the elastin layers, but also the endothelium seems to be different between extra and intracranial vessels, and there's a gradient from larger to smaller intracranial vessels. This is a difficult slide, but it's the introduction to some data that I'm going to show you on studies that we did using brain endothelial cells in culture. Here is atherosclerosis. I showed you data on that, foam cells, inflammation, LDL and HDL. But what I want to bring you to is this mechanism here. There's a defense mechanism because if atherosclerosis develops, there is also a defense mechanism involving antioxidants like hemoxygenase 1 that's also activated. So you see an increased expression of hemoxygenase 1, And that is driven by nuclear factor 2 that translocates, so that's a factor that translocates to the nucleus, and then hemoxygenase 1 production is activated. And that same French group that I already showed you data from that studied the development of atherosclerosis in the extra and intracranial arteries, they also studied magnesium SOD, so another antioxidant, in these intracranial and extracranial arteries in these same 180 subjects. And what you and you remember the data that there is a linear development of atherosclerosis in the common carotid and abdominal aorta, and there is this lag phase and then exponential growth of intracranial atherosclerosis. If you look at this antioxidant, you can see that the levels at young age in the intracranial vessels is higher, almost double of the extracranial levels, and that these levels of SOD, that they decrease over age, while they are more or less stable in the extracranial arteries. So this might be a kind of an endothelium defense mechanism that protects these intracranial arteries in the first 20-30 years from the development of atherosclerosis. We also studied this, but then in vitro, using human brain endothelial cells in culture. And we studied them, and we first tested reactive oxygen species production upon stimulation with ox-LDL. So we gave them 50 or 100 mg of ox-LDL, of course, also some TNF-alpha and interferon gamma to really test the reactivity of these endothelial cells. So the TNF-alpha induces ROS production. And what you can see here, that ROS production so that's the positive control, but here if we give them 50 or 100 micrograms of ox-LDL, there is less ROS production, so less reactive oxygen production in these brain endothelial cells. And if you do the same experiments with UVEX, so extracranial endothelial cells, there is an increase in ROS production. And this is the data on the translocation of nuclear factor 2 and hemoxygenase production. So it's the same experiment in these brain endothelial cells. They are stimulated with ox-LDL. You can see here that there is a very steep increase of, so there's much more nuclear factor 2 in the nucleus. So nuclear factor 2 really translocates to the nucleus if you give these endothelial cells ox-LDL, and there is an increased hemoxygenase 1 RNA expression and protein expression in these cells. So this is the protective mechanism that was already shown by this French group in the 80s in these autopsy series. So this is what we think is going on in these intra and extracranial arteries when they are seeing, for instance, oxidized LDL, that in the intracranial arteries, that this antioxidant response is much more impressive, much more articulated than in the extracranial arteries. So we think that the endothelium is playing a very important role in there. So that last part of my talk is really on imaging. I'll show you our first data on imaging of atherosclerosis in intracranial arteries and intracranial atherosclerosis. And this is an ex vivo approach. So we're not doing this in real patients. We're using a quite sophisticated MRI, 7 Tesla MRI, and we are doing really measuring long hours, more than 10 hours of imaging time. And so what we do here is we sampled again these circles of Willis. We selected rings from arteries in which we really could see by eye the presence of atherosclerosis, and then these rings were embedded in agarose, and then they were measured by in the 7 Tesla MRI machine in Utrecht. And we had already shown, that paper is just out, that we could see the thickening of the vessel wall, so we could see the presence or absence of atherosclerosis by this technology. But at that time, with the MR sequences that we used there, we were not able to distinguish different features of the atherosclerotic lesion, like calcification or lipids or fibrous tissue. So this study was set up to develop some MR sequences that could be able to distinguish specific plaque features. So we, in this study, we used 38 atherosclerotic specimens from the Circle of Willis, and really one-to-one correlated the composition of the atherosclerotic plaque visualized by histology, and to see whether the different MR sequences that we used, and they are named here, whether they could distinguish different features of intracranial atherosclerotic plaques. So this is the data from histology, and here is where this is the MR sequences, and we then really drew lines. What we thought by histology was the atherosclerotic lesion, where the calcification was, where the fibrous tissue was, etc. So this is the data, and this is unpublished data, and it shows you that the MR sequences that we use, especially the T1 sequence, was able to to characterize lipids, to see the difference between lipids and fibrous tissue, calcifications, the rest of the vessel wall, and the fibrous cap. So we are slowly developing, like people in the carotid artery already are doing with MR sequences, trying to develop the right MR sequences that can distinguish different features, different characteristics of the atherosclerotic plaque. This is, of course, work in progress. So I'm going to conclude with some suggestions on the heart-brain connections. We have set up a heart-brain approach in the Netherlands. It's really a multidisciplinary translational research program between these, involving 6 medical university centers in the Netherlands. It involves both clinical, experimental, and epidemiological studies. I've shown you here our design. From our work and from the literature of intracranial atherosclerosis, I think we can fairly conclude now that it differs from extracranial atherosclerosis. It develops in the brain. It doesn't stop when vessels go into the brain. And it's not only the architecture of the vessel wall that is different, but also the function of the endothelial cells is different in these intracranial vessels. And it seems that the endothelial cells protect the intracranial arteries more than in the extracranial circulation from oxidative damage. And we are starting to develop now MR sequences that can distinguish components of intracranial atherosclerotic plaques. So this is really the most important slide, where I want to thank all the people that are involved in these studies. Of course, the many people in the Dutch Heart-Brain Consortium, in my group, in the AMC in Amsterdam, a very nice collaboration with the Utrecht group, MR sequencing group, led by Jeroen Hendriksen. We are the endothelial cells culture studies were done with Elga de Vries in the other Amsterdam Medical University Center at the VU Medical Center. And the experimental studies in the mice we're doing together with Louise van der Weert in Leiden. And I want to thank all these people that helped me to really prepare this, the data for this talk. Thank you.
Thank you, Dr. Damon. No, stay here, please. Stay here. Unless you want to sit there. Okay. Maybe sit there would be better. Right. So we have some questions from the audience. Let's repeat that question with a microphone.
Well, thank you very much for your talk. It was very informative. As a researcher who does research on intracranial atherosclerosis, this is a question specifically for you. I'm a vascular neurologist. I also work with vascular neurosurgeons. There's always this lingering question that what shall we do with intracranial atherosclerosis? Because on one hand, my colleagues tell me a degree of intracranial atherosclerosis is necessary because if you suppress the atherosclerosis completely, this can lead to softening of the arterial wall and eventually increases the risk of intracranial bleeding. On the other side, they tell me that if intracranial atherosclerosis continues, eventually it leads to ischemic stroke, which is a scenario we see every day in reality. So as a scientist, I would like to know, what do you think about this comment? Because I keep hearing this, some degree of atherosclerosis is necessary to prevent intracranial bleed. What is your opinion?
I'm a little bit biased because I'm a pathologist. So I've never heard this theory that you need a little bit of vessel hardening to really protect it from bleeding. I don't know whether there are real data on that is actually true. So I don't favor that hypothesis.
This is basically a clinical comment I receive from neurosurgeons. It's not really that I believe in it, but this is what they are telling me.
Yeah. So I would really like to see the data on that. So I'm a disbeliever of that part.
All right. Thank you.
And in fact, that's really what we're also testing in this study, because we measure the pulse wave velocity in all these patients with MR. So we will get the data that might answer this question. Because the idea is that with if the pulse wave velocity increases, that is bad for brain function. So vessel hardening is bad for cognition. That's the assumption that the hypothesis that we are testing.
Very nice talk, Dr. Damon. One of the things that I guess we were having a discussion with Dr. Beggs out in the hallway. So the changes in the composition of the matrix wall where it becomes less elastic, I guess what that would do is that would be communicate, when that becomes harder, it's less compliant. And so you're going to be communicating pulsatility downstream to the microvessels, as Clive pointed out, which normally experiences laminar flow, but not pulsatility.
Yeah.
So do you expect, I expect, some of my work says that changes in the pulsatility and the shear profiles that the endothelial cells are exposed to has a very important effect on this.
Yep.
So
does this fit? I agree with that. That's exactly the line of thinking we are following. Yeah. There's also already associative evidence for that. Interestingly there, and we can have that discussion tonight or tomorrow, is where the main pressure drop is in the brain. And that there is some data that is earlier than we think, that there was already a huge pressure drop early in the arterial circulation. So that would dampen the pulse pressure, the effects of the pulse pressure much more than we might assume if we didn't know this. Yeah.
Thank you.
Thank you. Well, very interesting. We're certainly looking forward to your presentation 5 years from now, too. A lot of different parameters you're trying to bring together here, which is nice to see. I have some specific questions for you. One is, in your MR protocol, are they collecting quantitative flow information so that they're mapping the inflow and outflow, say using 2D flow quantification techniques, for example, so you could potentially monitor the change in perfusion to the brain even without doing ASL or PWI, and you could compare, do these patients who, say, have intracranial hypertension or who have left ventricular hypertrophy, for example, if you can successfully treat them, can you show that these white matter hyperintensities that you alluded to actually go away with increasing and improving the perfusion after treatment of, say, carotid atherosclerosis? Is there any evidence that that happens? So sort of two questions there. Are you measuring the flow, and can you demonstrate that there's actually a reduction of white matter hyperintensity in the process?
So the first, the answer to your first question is yes, we're measuring flow in a quantitative measure, so we can do that. We have not designed an intervention, a controlled intervention in these studies. We're doing a longitudinal study, so we will have 2-year follow-up and a repeat of the measurements, and there will be patients that will have a hypertension and will be treated. So we might get some of that data, but the study is not designed to really test that hypothesis, because we first had to get this we first had to get this data out before we can set the stage for an intervention, because we don't know the intervention yet, and we don't know. We first have to test this hypothesis, whether there's really an association between cerebral perfusion and cognition, because that's not proven yet.
That's true on the cognitive side, but people have been doing endarterectomies for a long time now.
Yep.
So there's a lot of MR data that is collected prior to the treatment, and my guess is that these patients have probably been scanned again after their endarterectomy, maybe not immediately, maybe a year later. I'm just curious if there are any papers out there that demonstrate after treatment, is there a reduction of white matter hyperintensity?
The Utrecht group has published that paper because they are experts in the carotid occlusion and they are treating these carotid occlusions there, and they show that if you treat the carotid occlusion, there is a reduction of white matter hyperintensities in these patients.
So that's some nice preliminary evidence to further promote you to do this study, because now you have some evidence that may have an effect. And do these patients also show improvement in cognitive function after endarterectomy?
They show,
Clive Beggs. Just some thinking on, you said that traditionally people haven't thought much about atherosclerosis in the brain, but what about leukorrhiosis and hypertension? And I mean, you get increased pressure drops there because you get narrowing of the vessels. Do you have any feelings that your work relates to that?
Yes, that will probably relate, but we're not going to be able to test this in this group, because we will not have a lot of material of that now.
Okay, I just wondered what your feelings were on that.
There is a lot of data and literature on small vessel disease, and especially in hypertensive patients. And I think that, of course, as the heart is connected to the brain, because I think that's clear, there is also connection between the larger arteries and the small vessels. That's why we also include this VCI group, which have more or less clinically proven small vessel disease. These symptoms that are linked to small vessel disease. That's why we're including those patients.
I'm Ivo Petrov from Bulgaria. Great talk. Thank you very much, Dr. Damon. I like very much what you say about the relationship between the heart and the brain. I see a lot of common between the ischemic cardiomyopathy that is most probably due to chronic lack of perfusion, and as Mark just said, most probably the lack of brain perfusion, the chronic lack of brain perfusion, is also one of the predisposing factors for dementia and other degenerative diseases. And we see in the daily practice in patients with bilateral subtotal carotid stenosis that after the opening of such a stenosis by surgical, or in our case endovascular means, most of the patients improve their cognitive function. And your work is encouraging and confirming our data in the clinical practice. Thank you.
Thank you, but I'm not going to give you a few data against my own hypothesis, because we are already doing some work in the animals, So if we look in mice, we studied also extra and intracranial atherosclerotic in the classical mouse atherosclerotic model, so ApoE mouse, LDL receptor mouse, and there is no intracranial atherosclerosis, and they have massive extracranial atherosclerosis, but it really, if the vessel really almost penetrates into the skull, we haven't seen one single foam cell in these vessels, and we really look for it. So
what is the reason of this mismatch?
I think
your
the
opinion?
The endothelial cells. We're testing the endothelial cell hypothesis there, and there's a lot of hemoxygenase production in these endothelial cells. They have very lots of caveolae, very tight junctions in these intracranial vessels, and of course these are tiny vessels. So size matters also. They're already very small vessels.
It would be quite interesting to extract an index, predictive index in such cases. So who will respond with improvement of cognitive function and who will not,
sure.
based on the diffuse or not so diffuse changes.
And some and also data from mice again. If we do a myocardial infarction in a mouse, so ligate in the left coronary artery, and we study cerebral perfusion in these mice, even when they have relative massive left ventricular failure, cerebral perfusion is more or less intact. So it's very well. Autoregulation is very strong in intracranial.
Great, thank you.
Thank you, Dr. Damon. Appreciate it.
Thank you to everybody. It was a long day today, and that start with the ultrasound course, and tomorrow we open the convention of ISNVD, and that confirm to be an association that involved in the research and the top in the world. And see you tomorrow. Now we have a dinner in the next. Thanks.